Good afternoon. It's a pleasure to be here, and I'm particularly excited about this webinar because although everybody talks about attachment and usually looks at social determinants of attachment, I want to take this a little bit further and look at the neurobiology of attachment, especially as it pertains to the special populations we work with, women and families affected by substance abuse during pregnancy. So let's make sure we all agree on the definition of attachment. Attachment is the interconnectedness between human beings. It requires each of the individuals in the attachment relationship to read each other's cues and then to respond appropriately to each other's cues. And this is where some of the misinformation arises. Most people will talk about maternal infant attachment from the perspective of the mother. And you have to realize that's only half the equation, because not only must the mother be able to read her infant's cues and respond appropriately, the infant must read his or her mother's cues and respond appropriately. And so in this webinar, I want to look at both sides of the equation, both from a social and environmental perspective, as well as a biological perspective. So as we begin this discussion, we're first going to focus on the mother. And as I said, there are two essential maternal qualities for attachment: responsiveness, being able to respond to the infant, and accessibility, being accessible to the infant. And as we discuss this, I want to look at the functioning of the human brain from the perspective of information processing. Now, many of you have heard me talk about information processing before, but this is essential to understand our further discussion. So let me review it very briefly. There are four domains of information processing: input, integration, memory, and output. That is the way we bring information into the brain, the way we interpret it, how we store that input for later use, and finally, how we use language and motor skills appropriately to respond to the original input. So let's talk about the brain for a moment. You can see here the basic lobes of the brain, the frontal lobe. And in the frontal lobe, there is a very important area known as the prefrontal cortex. And the prefrontal cortex is the regulatory center of the brain. It's where dopamine is located, and we're going to talk much more about that in a moment. Up toward the back and top of the brain is the parietal lobe. In the very back of the brain is the occipital lobe. Then you see the cerebellum, and moving on clockwise, you see the temporal lobe. So those are the basic areas of the brain. Now that's not so important, but here's what you need to understand. Information comes into the brain through different pathways. So now we're talking about input. When you use visual or bring in visual information, the information enters the eye, travels along the optic nerve, and inserts in the occipital lobe in the area known as the visual cortex. So visual information enters the brain through the very back of the brain, the occipital lobe. Auditory information, everything you hear, enters through the ear, travels along the eighth cranial nerve and inserts on the midline of the brain. And taste, touch, and smell enter the parietal lobe. And so information enters through multiple pathways. The job of the brain after input is to integrate that information, to make sense of it. And that occurs toward the back part of the brain and the mid part of the brain. Many of you have heard of sensory integration. Then once that information is integrated, it's stored in memory for as long as you need it. And then when you need the information moves forward through the brain to the prefrontal cortex, where essentially dopamine fires off and tells you how to use that information. So let's just look at an example. Visual information enters the eye. So let's say you're walking along the sidewalk and you see a car coming. The image of the car travels through the eye along the optic nerve to the back of the brain and inserts on the visual cortex. Flash, there's the car. That information then shoots forward to the prefrontal cortex where dopamine fires off and says, stop walking. That is called motor regulation. So you're going to hear me talk a lot about regulatory behaviors. Now, let's apply this information to the process of attachment. And this is a graphic that Strathern and his colleagues who study attachment in adults and infants, this is a graphic they developed, and you'll see the asterisk. I inserted the asterisk just to show you where our point in this cycle is going to begin. And what you see here is that in the maternal brain and in the endocrine response system of the mother, the two key pathways responsible are that have a role in attachment from the maternal perspective are the dopamine pathways and oxytocin. Attachment is based in both the dopamine and oxytocin response pathways. So dopamine and oxytocin contribute to the maternal caregiving environment, both pre and postnatal. The infant responds through attachment by building its dopamine and oxytocin systems so that the infant can then demonstrate attachment behavior. You have ongoing environmental influences. So as the individual matures, that individual develops strategies for adult attachment. And so the cycle goes. And at the heart of this, of course, is genetic variation and epigenetic adaptation. So this essentially is the cycle that we're going to be looking at. Now, let's talk about factors that affect relationships in chemically dependent women. If any of you have worked with women who have a history of chemical dependence, especially during pregnancy, you know many of them come from a negative heritage, that is, a family history. And where is it we learn to be parents? It's from our own parents. And most women who are chemically dependent as adults have come from families that are dysfunctional, that they didn't have the opportunity to observe and learn from a parenting framework. The families often are families of dysfunction. You add to that many chemically dependent women are emotionally unstable, especially from the perspective of experiencing trauma. And there has been a number of studies that have looked at histories of trauma in women who are chemically dependent. And it's found in some studies up to about 90% of women who are using and misusing drugs and alcohol in adulthood have histories of early childhood trauma. Most significantly, histories of sexual trauma. The third area is a lack of social support. Families with histories of are evidence of chemical dependence, addictions, and violence within the family are what we term avoidant families. They lack the usual systems. They avoid the systems who might call their addiction or intrafamily violence to the attention of authorities. And so if a child grows up in this kind of avoidant family, that child grows into an adult who is avoidant. So what we find is many women with histories of chemical dependence are socially isolated. And one of the key factors that differentiates women from men is that women's lives revolve around relationships, especially relationships with other women. And if you work with women who have histories of addiction, you'll find that many of them have never had a relationship with another woman. And that's vital just in normal human development, that adult women have relationships with other adult women. Rather, many of the women we work with are isolated and dependent on their partner. And their relationships with other women have often focused on competition, competing for love, sex, drugs, and money. And so there is that lack of social support. The fourth element is cognitive functioning. Now, we're not talking about IQ necessarily. What we're talking about is is broader than that. And we really get into the arena of neurocognitive functioning. And just as an example, I want to talk about these MRIs that you see in front of you now. Now, on your left, top and bottom, are the normal MRI of an adult woman looking from the posterior to the anterior brain. And these are two cuts through the brain on MRI. On your right, top and bottom, are similar cuts of an MRI for an adult woman with a history of alcoholism. Now, we're going to compare the top two. So on your left is the normal MRI. On your right is the MRI of an adult alcoholic woman. And if you look at these, you'll see that one of the first things that's noticeable is that the dark spaces in the middle of the brain are much larger in the woman with a history of alcoholism. These dark areas are known as the ventricles, and on the left you can see the normal size of the ventricles. The ventricles are the empty spaces within the brain through which the brain receives its nurturance through the cerebral spinal fluid. When a woman, or man for that instance, has a history of chronic alcoholism, alcohol can literally kill brain cells. And as the brain cells die off in the area around the ventricles expand. And this is essentially why you see someone with chronic alcoholism, it affects overall cognitive functioning, that is IQ. Now the bottom two demonstrate something different. On the left is the normal MRI. On the right bottom is the MRI of the woman with a history of chronic alcoholism. And right in the middle of the bottom on the left, you see a U-shaped organ right there. And you can see that that appears to be a bridge between the right and left sides of the brain. And in fact it is. That's called the corpus callosum. And the corpus callosum is what connects the right and left sides of the brain. It's how we move information from one side of the brain to the other. On your right lower picture, you can see the MRI of the alcoholic woman. And look now at the corpus callosum, and what you see is that this U-shaped organ has thinned out. And in fact, this is called thinning of the corpus callosum. When a corpus callosum is thinned out like that, then information has much more difficulty moving between one side of the brain and the other. And so what you get is difficulty with executive functioning, that is the ability to plan and complete a task. A good example of that would be if you make an appointment with a woman, let's just say you're a home visitor, and you're visiting a woman with a new baby. And you tell her, okay, next Thursday at 4 o'clock, I'll be back. And the woman writes the appointment down on her calendar into her smartphone and says, fine, I'll see you at 4 o'clock. Next week comes, you're at the house, 4 o'clock, and the woman's not there. But you wait. 4:15, 4:30, 4:45, the woman shows up. And you look at your watch, you say, what time is it? The woman says it's 4:45. And you say, well, what time was our appointment? And she says 4 o'clock. So she knows cognitively that her appointment was 4 o'clock. But to take that information that she knows cognitively and move it to a higher level of functioning, she has to have an intact corpus callosum. It's part of the pathway. And so you have to work with her and become what we call her external brain. That is, teach her to plan ahead. And that's a process that you can go through. But this is just an example of how it takes much more than, quote, parenting classes to be able to change behavior over the long term with a woman who has a history of alcoholism. The fifth factor is psychological functioning. One of the other differences between men and women, especially when you look at the fields of addiction, is that women with histories of addiction have a significantly higher rate of co-occurring mental health disorders than do men with histories of addiction. And the most common diagnoses we've made in women, pregnant women who were in our substance abuse treatment programs, were depression and borderline personality. Most people can easily see how depression would affect a woman's ability to parent a new child. But what about borderline personality? Borderline personality is when an individual is very egocentric, sees everything that occurs in the world in the context of how it affects him or her. It's difficult to not only empathize but sympathize with others. And so if a new mother has a borderline personality or is suffering from depression, you can see how difficult it would be for her to read her infant's cues and to respond to them appropriately. The sixth factor, and one of significant import for us, is substance abuse. Now, to fully understand this, I want to review the neurological functioning of everyone's nervous system. And this is just very basic, but as you know, we send electrical impulses from our brain to, for example, our fingers, to tell our fingers to wiggle. And the way that we send that electrical message is through the nerve pathways. And it's not one long nerve, but it's a series of nerves. And as that electrical message reaches the end of one nerve, that electrical message must move across, jump across the nerve gap to reach the next nerve so that it can travel on. The way these electrical messages are carried across the nerve gap is through the neurotransmitter system. Neuro, meaning nerve, transmit, so the neurotransmitter system. And most of you are familiar with neurotransmitters, dopamine, serotonin, norepinephrine. In this case, we're going to focus on dopamine. So what happens is the electrical impulse travels along the nerve pathway, hits the end of the nerve, the dopamine picks up the electrical impulse, carries it across the nerve gap, where it's released and the electrical impulse moves on through the nervous system, and then dopamine circulates back into the proximal or first nerve ending, and that's called reuptake. So again, dopamine picks up the electrical signal, carries it across the nerve pathway, releases it, and then circulates back to the first nerve ending, where it is stored in the dopamine receptors. Now, there's one problem here. Dopamine is part of the regulatory system and participates as the regulatory center of the brain. But dopamine also serves as the pleasure center of the brain. And so when you, let's say, eat something that you like, your dopamine levels rise about 125 to 150%. If you smoke a cigarette, nicotine increases dopamine levels by about 200%. Cocaine increases dopamine by 300%, and methamphetamines increase dopamine by 1,000%. So, for example, methamphetamine causes excess release of dopamine from the first nerve ending across the nerve gap to the second nerve ending. So that's what produces the high, is this massive release of dopamine. For cocaine allows a normal amount of dopamine to cross the nerve ending. But as the dopamine circulates back for reuptake, cocaine blocks dopamine reuptake. And so what you get in these situations is depletion of the dopamine receptors. Now, when your dopamine receptors are depleted, you feel irritable, off task, paranoid, can't function, can't focus. And so the only thing you can do to feel better is to use more of the drug, because that will stimulate whatever dopamine is still left there. And that's the process of addiction. You start using drugs to feel good, to get that high, but you keep using drugs so you won't feel bad. Over the long term, what that does is it depletes the dopamine receptors. Now, this is, on your left, a PET scan, and we're looking from the top of the brain down. And this is a 22-year-old young man who needed a PET scan and had a PET scan. And what you can see is the yellow and red is dopamine, because PET scans are used to show us dopamine in the brain. Now, this young man happened to begin using cocaine. And about a year after beginning his use of cocaine, he had another PET scan done. And what you can see on the right is that the yellow and red are gone. So the dopamine receptors have been depleted. So in our pathway, when we talk about maternal attachment behaviors, we've already said these behaviors are rooted in the dopamine and oxytocin systems. And if you have a depletion of dopamine on the mother's side of the equation, how well is she going to be able to read the cues of her infant and respond to them appropriately? Now, it becomes even more complicated, because what studies have also shown is that the chronic administration of drugs of abuse, such as cocaine, methamphetamine, heroin, substantially reduces oxytocin levels in the hypothalamus. So now you have a situation in which a woman not only has depleted her dopamine receptors because of ongoing substance abuse, she also has decreased her production of oxytocin. And at the very beginning of the pathway now, we have a woman who is a new parent, has a new child, has a history of substance abuse, having grown up many times in a family in which she had no models for parenting, has a history of trauma, and it goes on and on. So now that you have an adult woman at very high risk for not being able to really, on a neurobiologic basis, to be able to read the cues of her infant and respond to them appropriately. Now, let's set that aside for a moment and look at the infant's readiness for attachment. And in this case, we are talking about an infant born to a mother with a history of alcohol and drug use during pregnancy. And the key is, it bears repeating, that in the attachment equation, the infant has to be able to read his mother's cues and respond to them appropriately. Remember, it is a two-way street. So our question now, how does prenatal substance exposure affect the infant's ability to be accessible and responsive? And what we're talking about now is the biological basis of the behavior, both from an environmental perspective and a biological perspective for the infant. And this is grounded in the infant's exposure to trauma. Now, from an environmental perspective, we have to stop and think, okay, when does risks really start? Most people will talk about risk in terms of family history, in terms of what the child, what life the child is born into, looking at early childhood. But the reality is that risk begins at conception. And I want to go back to the earliest period after conception, the embryonic period. The embryonic period is the first 12 weeks after conception. And during this time, cells are undedicated. What that means is that although the embryo is growing and cells are multiplying, the cells don't really know what they're going to end up being. So some cells will end up being leg muscle, some cells will end up being bone, some cells will go to the brain. So these cells are undedicated. And the name for these cells are stem cells. And I'm sure all of you have heard about stem cell research. Well, the problem is during this embryonic period in which stem cells are pregnant, early gestational stress can affect the genes of those cells. The way this happens is called methylation. Now, what is methyl? The methyl group is a chemical compound made up of one carbon atom and 3 hydrogen atoms. And what happens is if a woman during pregnancy, during these first 12 weeks after conception, is under stress, especially emotional stress, that methyl groups will attach to the stem cell and actually will methylate the gene so that the gene is affected by the mother's stress. And this methylation produces epigenetic memory. And I know that many of you have heard about epigenetics. Epigenetics are genetic changes that occur because of what's happening in the world around us. In this case, what's happening to the developing embryo and fetus in his intrauterine environment. So that you can actually change genes through this fetal experience. And there are 2 basic hormones that moderate this. The first is serotonin. Serotonin is responsible for shaping the neuronal circuits in the frontal brain. And serotonin crosses from maternal side to the fetal side through the placenta. And serotonin is produced by the mother when she's relaxed, when she's happy. So serotonin is very soothing. And so a lot of serotonin on the mother's part passed across to the fetus is very beneficial to the fetus. Now, when the pregnant woman is experiencing fear or anxiety, her cortisol levels rise. And the cortisol is transmitted to the fetus via the placenta. And cortisol can disrupt these neuronal circuits and the development of appropriate hormonal pathways. Essentially what's happening is the fetus is learning what to expect in the outside world. And a way to think about this is there are 3 different ways to think about this. And Dr. Bruce Perry has talked quite a bit about the neurosequential development of the brain, very much from the bottom to the top. That is, from very simple functioning to much more complex functioning. From the back to the front, with the back of the brain, we tend to be reactive. With the front of the brain, with the regulatory center of the brain, the prefrontal cortex active, then we become very proactive and think ahead. And then the brain functions from the right to the left. The right side taking in novel information and moving it to the left so that it becomes familiar. In fetal brain development, the brain develops from the bottom to the top. The bottom of the brain being the brainstem, which begins to form around 33 days after conception. Many times this is before a woman even knows she's pregnant. And the brainstem is responsible for our basic instincts, our needs, survival. That's where the sleep center of the brain is located. And the brainstem has the ability to code, to receive, and to store trauma. And this is where the imprint of maternal depression, anxiety, and stress is stored in the fetal brain. The central brain evolves from the brainstem and develops by about 6 to 7 months gestation, and the central brain includes the limbic system. The limbic system is made up of multiple different areas, organs in the brain. The amygdala, which stores and is responsible for our visceral components of feelings. The hippocampus provides the ability for emotional memory. The thalamus is the central switchboard that determines what pain our brain can handle at any given time. The hypothalamus organizes physiologic responses to stress. And the pituitary gland governs release of key hormones. And any of these can be disrupted. Their normal development can be disrupted by excess cortisol crossing across the placenta from the mother to the fetus. And finally, the outer shell of the brain, the cortex, is the last to develop. Its major growth is in the third trimester and during the first year of life. And the cortex is responsible for intellectual functioning, for ideas, for thinking. And as I've said several times, it's all about regulatory behaviors, organizing information and responding appropriately. The left side of the prefrontal cortex deals with everything going around in the world, around us in the world, planning and completing tasks, decision-making, comprehension, interpretation. And the right side of the prefrontal cortex is internally oriented. It is responsible for bringing feelings over to the left side of the brain so that we can understand them. Now, what happens in addition to being exposed to cortisol and stress-producing methylation of the stem cells? What else is going on if the mother also is using drugs? And once again, I bring you back to this diagram and remind you that the dopamine receptor system is part of the neurotransmitter system. It picks up the electrical stimulus, carries it across, releases it, circulates back. That's the dopamine reuptake into the first nerve ending. And once again, what we see is that in the fetus, as well as in the adult, you can get depletion of the dopamine receptors from exposure to methamphetamines, to cocaine, to nicotine. Just about any substance you can name, any substance of abuse, will affect the fetal dopamine receptor system. And animal studies have shown us that the infant animal born, most of these studies are with rats, born to a rat who's been given cocaine during the pregnancy, those infants do have, in fact, depleted dopamine receptor systems. And that depletion continues into adulthood. And so what do we get? We get infants who are unable to regulate their behavior. And this is probably one of the reasons we see such a high rate of attention deficit and attention deficit hyperactivity disorder in children born to women who smoke cigarettes or use the illicit drugs, because there is depletion of the dopamine receptor system, which manages regulatory behaviors. And in fact, studies have shown that about 74% of prenatally exposed children do in fact meet criteria for a diagnosis of attention deficit disorder or attention deficit hyperactivity disorder. So what does that tell us for the infant? Using the same visual graphic from before, as information enters the brain through the various pathways, shoots forward to the prefrontal cortex that tells the infant how to respond. If the infant has depleted dopamine receptors, his regulatory behaviors don't allow him to be accessible to the mother, to read the mother's cues, and to respond to them appropriately. And so we have difficulties with attachment on both sides of the equation. And the ultimate difficulty is that the mother, because of her family history and the effects of drugs on her developing hormonal system, as well as the fetal environment's effect on the developing fetus and the effect of drugs on the dopamine receptor system in the fetus, what we get are problems on both sides of the attachment equation. And so the question now is, how do we promote attachment in a newborn who has been prenatally exposed to drugs and alcohol, and address the needs of the mother at the same time, so that we can support both sides of the attachment equation? Well, one of the most important and, in fact, easiest interventions available is touch. And if any of you took high school or college psychology, you're familiar with the studies of the infant monkeys. And what you have here on your right is a wire mesh monkey covered in terry cloth. On your left is a wire mesh monkey with no terry cloth covering. And what the researchers did is they took a group of normal infant monkeys and divided them randomly in half, so that half of the monkeys were assigned, the baby monkeys were assigned to the mother with the terry cloth covering, and half of the baby monkeys were assigned to the wire mesh monkey with no covering. All of the baby monkeys got the exact same amounts and types of formula. And whereas the baby monkeys who had the terry cloth covered mother, those monkeys survived and did quite well. The baby monkeys assigned to the mother with no terry cloth covering, just wire mesh, those infants died of starvation. And this was one of the earliest studies that showed that maternal nurturing and touching is needed to promote absorption of calories. And in an unfortunate natural experiment in humans, babies being born in Russia, Romania, who are raised in orphanages, have significant failure to thrive, because although they may receive bottles of formula with adequate caloric intake, those babies are never picked up, never nurtured, and have very little sensory input during the whole first year of their lives. And so they don't grow and thrive, and many do succumb to failure to thrive. It shows the importance of touch. So what can we do with this information? We promote, in our mothers that we're working with, we promote skin-to-skin contact. If you have a mother in your program, have the obstetric unit allow the mother to have skin-to-skin contact immediately after delivery, and encourage skin-to-skin contact. Breastfeeding also is optimal. However, many of the women do not want to breastfeed, or if they are to have any evidence of ongoing substance use, they should not be allowed to breastfeed. And we have another webinar coming up on breastfeeding in this population. But promote skin-to-skin contact as much as possible. And with the fathers, if you have the father of the infant in the picture, promote skin-to-skin contact with the father also. Also promote kangaroo care. These are called snugglies. Have the mother keep the baby in a snuggly close to her chest as much as possible. Just this promotion of touch will significantly increase attachment between mother and infant. And during feeding time, be sure you do some feeding observations and encourage the mother to not only give the baby a bottle, but to be stroking and touching and looking at the infant and interacting with the infant as much as possible, talking to the infant. So this multisensory input will stimulate the dopamine receptor system for both mother and infant and promote oxytocin release. The other thing you can do in the newborn is teach the mothers how to address the irritability that many of these infants have. It's a stepwise process because it's very easy to overload the infants. So if an infant is crying and irritable, the first thing to do is to swaddle the infant in a flexed position, give him a pacifier, and then lay him on his back in the crib. Then teach the mothers to step back, because what that allows is the mother to take a breath and to get organized herself. And if her behavior, her frustration with the baby's crying is escalating, this is the time for her to step back, take a breath, before she tries to proceed any further with the infant. If you swaddle the infant and give him a pacifier, you'll see that this will be quite soothing in and of itself. Then teach the mother to approach the infant quietly and pick the infant up, holding him at arm's length. So now he's not only swaddled, but he's getting tactile sensory input from the mother because she's holding him in her hands. Now he may get a little bit more irritable, but then he will begin to calm. And as he calms, then the mother can begin talking very softly to the infant in a soothing voice, giving him just soft auditory input. And again, he will become more out of sync, more dysregulated as you begin to talk. But if you just stay in a quiet voice, he'll begin to calm. And then you can bring the baby around to make eye contact. And this really is one of the most challenging types of sensory input for the infant is a face. And so if the infant gets excited, more dysregulated with looking at the face, then move him back out at arm's length again. Wait a bit and try again. And sometimes you may even have to hold the infant in a swaddled position facing out, away from the mother's face. In any case, this slow multisensory input will help the infant get to a regulated state where you can then bring him in and hold him and comfort him. And so the most important thing for the mothers to remember is take it in a slow, stepwise process, and when necessary, step back to get her own bearings and to calm down. Now, we do have a booklet that spells this out that we give to adoptive parents, and we have a special one we're developing now for birth parents that will take them through this process and guide them in soothing strategies for the infant who is affected by prenatal substance exposure. And then let me mention finally floor time. Throw away the bouncies, throw away the car seats. The best developmental toy for an infant is a blanket on the floor. Encourage floor time. Put the baby down on the floor on a blanket on his tummy and have the parent get down on the floor with him. This will help build his central muscle tone. It will also help build his neck muscles. It also will overcome some of the spasticity the infants often have in the extremities, and the infant will learn to be very social while down on the floor. So floor time is another excellent approach. As the children move from early infancy into later infancy in a young child, remember that attachment is all grounded in relationships. And as the child, from the beginning and as he grows, you want to have nurturing bedtime rituals. And let me say here and emphasize the importance: we do not allow children to cry themselves to sleep. Let me say that one more time. We do not allow children to cry themselves to sleep. They may go to sleep out of exhaustion, but think of the lesson you've taught that child. The most important thing we can do for infants is to let them know that we are there for them. And a mother or a father or a caregiver must be available to that infant at all times. Play baby games with the infant as he gets older. Remember nurturing touch. And this is something that when I work with our birth parents, with our foster and adoptive parents, some of them look at me like I'm crazy. But my advice is you do not have any babysitters for the first 3 months at least, and hopefully 6 months. And I've written many letters to employers emphasizing the need for at least 6 months of maternal and or paternal leave, so that baby learns over his first 6 months of life, he learns who's always going to be there for him, while the parents learn to read that baby's inner life. And that's what attachment is all about.